Our next speaker is Dr. Steve Schall. He received his Doctor of Dental Surgery in 1978 from some school in Columbus. I'm sorry, I'm from Michigan, okay? He's on the staff at St. Charles, St. Anne, all the Saint hospitals. He's at all of those, and also at Toledo and Flower Hospital, and is an active member on the local level with the Toledo Dental Society. Dr. Schall.
Well, I'm not sure whether it's good to be last or bad to be last. I'll give it a try. As I've gotten involved with the dose committee, I've thought a lot about, or I started to think a lot about my prescribing habits. And most of the dentists and most people are creatures of habit, and we talked to Fred about this, that in my office for many years, before I ever saw a patient, when they came in, the staff would print out a prescription for 20 Vicodin, and it would be in the chart, and when I would take care of them, I'd just sign it, and the staff would go ahead and give them instructions, and I'd walk away. And it didn't matter whether it was a difficult extraction or one that almost fell out in my hand. I didn't think twice about it. I was very naive. I figured that they would take what they need and either dispose of the rest, or like me, it would sit in their medicine cabinet for a few years until you went around and cleaned out your medicine cabinet and then got rid of it. And it wasn't until I got to the committee and we talked about some of the issues that I really thought about these things, and certainly it has changed my prescribing habits significantly. And we thought at the committee level that, you know, some of you guys were probably doing the same thing, and it was an idea to come up with a handout. It's in everybody's manila envelope. You don't have to take it out now, but I'm going to go over it and you can look at it. But we thought that we would come up with some prescribing guidelines to try and help you guys out. And I got to thank Matt Dietrich and Bill Carroll, because they did most of the work and they let me come up and present it. But we kind of put our heads together and talked about these types of things. Anyway, one of the things that we talked about was trying to create a positive expectation for the patient as far as their postoperative pain. Now, I'm on staff, as Fred said, at a lot of hospitals, and today I had 2 emergency inpatients come over from St. V's, both of whom had swollen faces and abscessed teeth. And the very first question out of each of their mouth was, is this going to hurt? And I, try and explain to them, well, you make it difficult when you have a swollen face and a lot of infection, and every dentist sitting here knows that those people are very difficult to get numb. And I'm honest with them. I said, yeah, it's going to hurt. It's going to hurt a little. I'm going to do my best to get you numb, and I'm going to manage the pain afterward. And we're going to talk about that, and I'm going to prescribe you a few pills, and you're going to take Advil and Tylenol, as these guys have said, and you're going to use the ice and those types of things. And, try to establish a rapport with these people, and that worked pretty well. It says that we should be kind and gentle in our approach, and these people are scared, and even though, we didn't do anything to cause their problem, they brought this on themselves. Most of them are pretty much scared to death about this. They don't go to the dentist, and they come in when they're in pain, and it does help if you show them a little compassion and tell them that you're going to try and help them. So that's something that we routinely do. Now, obtaining effective local anesthesia, I said, is sometimes difficult in some of these people. And in our office, we do see patients that are difficult to numb. Some of the dentists will send them over, and we'll give various kinds of blocks that some of the dentists are not necessarily comfortable doing. We always give them a little bit of local ahead of time, let it soak in for a minute, and then go ahead and then block them if we can. I find that Articaine or Septicaine works well for me. It does allow better local anesthesia in the face of infection. As you guys know, when there's an infected area, the pH is pretty low, and Articaine comes out of solution better and works in that situation. We will many times give them some Marcaine at the end. We'll block with Marcaine so that when they go home, they'll stay numb for a long time. I discuss it with them ahead of time, and I tell them, if you don't mind having a numb lip or numb tongue, for 6 or 8 hours, you won't have much pain. Certainly we tell them that they have to stay on a liquid diet. If they try and chew with a numb lip or numb tongue, you can imagine what happens. So we have to discuss that with them. But generally that works very well. And as and Matt kind of stole my thunder here, we do prescribe for everybody to go ahead and take some ibuprofen. Usually we tell them to take 3 Advil 4 times a day, take it routinely. It's important that they take it around the clock, whether they're having pain or not. And this does seem to work very well. If they'd rather take naproxen, they can take that, 2 tablets twice a day. And we usually tell them to take it for 3 days. Again, whether they're having pain or not, we want them to keep taking it. And of course, we want them to take it before the local wears off. Now, if they have more pain, as Matt indicated, we can use Tylenol. And we tell them every 3 hours you're going to take something. You're going to take 3 Advil, and 3 hours later you're going to take 2 Tylenol. And 3 hours later you'll take 3 Advil, and then 3 hours later you'll take 2 Tylenol. And this way they're going to get 3 grams of Tylenol, which is the maximum they should take in a day, and 2,400 milligrams of Advil, which is the maximum they should take in a day, and they try and take it around the clock. And that combination, in combination with, as Fred said, some ice and elevation of the head really makes a huge difference. And again, this is not something that I ever thought about. I always just writing prescriptions for 20 Vicodin and sending them on their way. And like I say, this has really opened my eyes. We do have patients that we do some fairly traumatic things in our office. Not everybody here is going to do those types of surgeries, but we will go ahead and give them some Decadron, some dexamethasone. Many times we'll have an IV in them. We'll put these people to sleep for some of these difficult things, so we'll give it intravenously, but there's no reason you can't take 8 milligrams of Decadron the first day, and then 4 the second and 4 the third. And you just write for 4 pills and tell them to take it that way, and it really will significantly help the swelling. Of course, I tell patients that gravity is your best friend or worst enemy, so I tell them they have to sleep with their head elevated and keep the ice on for the first 2 or 3 days. As you know, peak swelling is 2 to 3 days. Now, if we're going to prescribe an opioid, we want to be certain that they're taking the aspirin or the Advil and the Tylenol the way they should be. A lot of times they'll figure they don't need it if they're not having pain. And we try and stress that, but they'll still forget to do it. The other thing that we find is that sometimes patients will come in and we're concerned that they're trying to abuse or hit us up for pain medicine. And we do use ORS, which is the Ohio Automated Prescription Reporting Service. And everybody in the room probably got a recent note from the state board kind of urging us to use this. We had some discussion with this at the committee level because some of the guys said, hey, I have patients that I've known for a long time, and they come in, and we can all tell these patients because they usually ask for a specific prescription by name. They'll say, you know, Tylenol 3 doesn't work, Percocet doesn't work, Vicodin doesn't work, I need Dilaudid, or something crazy like that. And of course, this is going to raise a red flag for all the dentists sitting in the room. But they say, you know, I'm a little uncomfortable. I've got a patient, I don't want to offend him, so I don't really want to, you know, approach this or broach this issue. Well, I use the ORS, and I tell them, you know, the state requires me to check all of my patients when we're writing prescriptions. You and I both know it's not true. We don't have to check ORS unless we're writing prescriptions for over 7 days. And no one in this room should be writing prescriptions for over 7 days as a general rule. But it's an easy way to use it as an excuse and say, hey, I had to check this, and I just noticed, you know, you got 82 pills in the last 3 weeks. Now, I'm afraid to give you a prescription for Dilaudid because I'm afraid you're going to become addicted. You don't really want to be addicted to this stuff, do you? And it's a very easy way to use the state and ORS as an excuse to check on these people and figure out, you know, maybe who's abusing or overusing these meds. So I think everybody in the room, if you're not on ORS, you need to get on ORS and then use it in those situations. You're going to be, of course, careful with prescribing the least potent opioid. You don't want to prescribe anything that's long-acting. We're not using Oxycontin for our patients. You can give them oxycodone or hydrocodone. Remember, oxycodone is 1.5 to 2 times as potent, and you're going to just give them enough for 3 to 5 days. The patients that when we write these prescriptions, we used to get calls, hey, I lost my prescription, you know, the dog ate it, all kinds of excuses, and we would just write them another prescription. Now we tell them, you know, this is gold. If you lose this thing, you're not getting another one. One of the things that we've done that's helped us a great deal in our practice is on our answering machine for the office and in our waiting room, we say, we will not prescribe after hours. And when we started doing that, we stopped getting all the calls from people saying, hey, you know, I have a toothache, can you phone in a prescription for pain medicine? I'll be there on Monday. We just tell them, I'm sorry, we can't do that. It's our policy. If you're really in that much pain, I can phone in an antibiotic. You can take the Advil and Tylenol, and if you really feel you need something more than that, you'll have to go to the go to the emergency room. And since we started doing that, and I think you guys should consider doing this, you won't be getting the calls at night and on the weekends for your pain medications. We also discuss with the patients now what to do with the meds when they're done. I say, if, you know, we write you a prescription for 5 or 6 or 10. If you're not going to use them all, you have to be careful that nobody else gets a hold of these. Don't give them to your friends. Don't give them to your family members. It's illegal. And when you're not going to use them, dispose of them. We talk about the fact that there are a lot of sheriff's departments and other places. There was a table clinic out there about ways or places to dispose of these meds, and we tell them about that. So that has, like I said, really changed our prescribing habits. Just some notes. Remember that most of these protocols are for the 150-pound person. Obviously, you have to change your dosage based on age, weight. My mother is visiting. She's 87 years old. She recently has told me that she had to cut back on most of the medicine she's taking. She still takes them, but she's taking lower doses. We find that the older individuals cannot tolerate or take those meds. They're much more sensitive to them. As Dr. Forney said, anybody taking other medications, CNS depressants, antidepressants, any of those other medicines can have a cumulative effect, and so that's why it's important when you guys see these people, ask them to update their medical history, check their medications. There's all kinds of apps for your smartphone that talks about various drug reactions, and you can just type them in and it'll tell you, if you don't know ahead of time, what medications can react with the narcotics that you're prescribing. And potentially you're going to save somebody a lot of aggravation. For patients who have liver or kidney disease, you have to be a little bit careful. Tramadol is a drug that we use for people who can't take narcotics. It has a very low abuse potential. People that have kidney disease cannot take nonsteroidal anti-inflammatories. I have some renal failure. I have a chronic shoulder issue. I personally am taking Tramadol twice a day. It works great. I have no ill side effects. It's not addictive, and it's a great drug for those people that can't take codeine. We used to have Darvocet years ago. We used it for many years, and unfortunately Darvocet went off the market. So Tramadol is really our best and only option for people who cannot take codeine, and you'll certainly have patients walk in who will tell you that they can't take it. Also for nonsteroidals, people who have ulcers or GI problems shouldn't be taking that. Patients with liver disease shouldn't be taking Tylenol. So these people can take Ultram, 50 milligrams every 4 to 6 hours. Again, you're going to give it for 3 to 5 days as a general rule. Certainly, there are plenty of patients who have chronic pain. We as dentists should not be treating chronic pain. There are plenty of chronic pain management centers around, and anybody who is in that position or needs that can certainly follow up with that. These are some of our references. When we started researching this, I did try and find some references for proper prescribing, and quite honestly, there aren't too many for dentists. The ADA has a practical guide, and we took a lot of this information out of there. Now, there's one more thing that I have on here that is not on the sheet, and I wanted to put it on here originally, and then we decided not to put it on. Recently, our association, this is in the Oral and Maxillofacial Surgery Journal, has started advertising a product called Exparel. Now, I became Exparel. My partners who do some cleft palate surgery will go in and take hip grafts. and they use the Exparel to inject around the hip. It's an ultra-long-acting local anesthetic. And they inject it around the hip, and the patient has literally no hip pain for 3 days. They can get up and shortly after surgery, get up and walk around. I used to say we love patients that we would need to get hip grafts from because they never complained about their jaw. They only complained about their hip. Now with Exparel, they inject the Exparel around the hip, and these patients can get up and walk around. Well, recently they have been approved for oral surgery for third molars, and now they're advertising in our journal. When I was just at our national meeting a few weeks ago, they had a booth, and I went up to the guy and I said, "You guys are missing the boat. There's 100,000 dentists in the United States. Every one of them would use this stuff if you would put it in a dental carpule and show them how to use it." And he said, "Well, you're about the 8,000th person that's come up and told me this." I said, "Well, it's obviously true." Recently, on my last slide here, was an advertisement that I received in an email from the ADA. So now they must have taken to heart what all of us told them at the national meeting, and now they're actually advertising this product to the American Dental Association. Let me tell you a little about it. It's a liposomal injectable solution, and it's been approved for third molars in patients over 18. Now, my partners are using it in children. It's off-label for children. If you're using it for people who are taking out wisdom teeth and they're 16 years old, you're using it for off-label, but it still works great. There's a significant reduction in postoperative pain and consequently a significant reduction in opioid use. You don't give it as a block. When I mentioned this at the committee the other day, Bill Zahari looked at me and said, "Great, somebody's going to walk around with a numb lip for 3 days and chew the heck out of their lip or tongue." And I said, "No, what they're recommending is that you use it as an infiltration. So you infiltrate it around your surgical site, and you would go ahead and give your block to do your surgery, and then afterward you can inject it as a infiltration in the submucosal area adjacent to where you're working. You can mix it with Marcaine if you want. You have to mix it 1 to 2 with Marcaine, or you can give it after Marcaine, but you can't really use it right after lidocaine. You have to wait and give it about 20 minutes if you have injected lidocaine in the area. So what we can do is inject it after we're finished. So we can do the surgery, and at the end, after we're done, we can inject it submucosally. Originally, when I looked into buying this stuff, they were only selling it in 20 cc bottles and 20 bottles in a pack. So it was $400 a bottle. So it was $8,000. I said, I'm not going to buy $8,000 worth of this stuff. That's crazy. So now they have come out with 10 cc bottles, and they sell it in a 4-pack. So we have ordered a 4-pack for our 3 offices for patients that we may need to use it. You can re-inject it after 4 days if you need to, and it has a 2-year shelf life. The problem with it is as soon as you open the bottle, you have to use it. It can be refrigerated for 2 years, but once you open the bottle, you have to use it within 4 hours. And theoretically, you should only use 1 bottle per patient. I'm not saying that that's the way we're going to use it. I'm just telling you that's the way the company is advertising it. Anyway, if you wanted to order it, Pancera Pharmaceuticals sells it. And this is the advertisement that I received about a week ago from the ADA. So again, this is something that I think ultimately they will figure out the market is there, and they will start putting it in dental carpules. It may be $50 for 2 carpules. You'll keep it in your refrigerator for somebody that's willing to pay for it and have 2 or 3 days worth of pain relief. For a difficult surgical procedure, you probably can talk patients into it. So that's something that's not on the sheet, but something that I think we'll be seeing in the future. Anyway, when you guys get home, take a look at it. If you want, we laminated it so you can put it up next to your desk as a quick reference. Anyway, thank you very much.